It's about 1:05, June 26, 2024. This is the opioid settlement group of the Lewis and Clark County Metro Region Governance, the Opioid Settlement Governance Committee. Let's take a minute, and if you'll call roll, and we'll ask the other folks to introduce themselves.
My pleasure, Chairman Rolfe. Mayor Collins.
Here.
Councilman Feist.
Here.
Committee member Colleen Smith. Here. Committee member James Petrovich.
Here.
And Chairman Rolfe.
And here. All right. Are there any corrections or additions to the previous minutes? I just wanted to anybody have any questions on the bylaws that we finally arrived at? Any questions that come up that we need to be discussed at some point? All right. If there is there a motion to accept the minutes as written? Motion by Colleen, second by the mayor. Okay. All those in favor say aye.
Aye. Aye.
Opposed, nay. Motion passes 5-0. We've got two kids here today to talk about some potential uses of the opioid money, and I thought we'd start off with that. We've got first the Lewis and Clark County Sheriff's Office, and I'll just turn it over to you if you'll introduce yourself to everyone, Captain, and we'll go from there.
Yeah. No, thanks for having me this morning. Most of you know me, but those that don't, I'm Bradley Bragg. I'm the detention captain for the Sheriff's Office. Been with the Sheriff's Office for 12 years, running the jail for the last 2.5. So kind of had to switch from working the streets to sitting behind a desk and running a jail without any experience doing that. But been drinking through a fire hose and getting up to the speed on it. So our proposal for the opioid abatement money is directed towards us getting a medical provider within the detention center. So I'm going to go through some of the different areas and kind of the benefits, the areas that it's going to cover underneath the approved uses, and then we'll have time for questions. So one of the big reasons we're looking for being able to have a medical provider in the facility is it helps us with meeting Montana jail standards. So Montana jail standards are a voluntary thing that local jails all comply with to make sure that we're doing the right thing for the inmates without having to have the state tell us what to do. Chapter 11 covers medical standards, and the facility has access to a physician or other health authorities such as a hospital or clinic to provide health services. So right now we have a partnership with Peerview Health Clinic where we can transport inmates to their facility for medical, including for opioid use disorders, and getting them on our Matt Bridges program. However, they are not able to provide services within the facility. So it does require transport by our officers to the actual appointments. So it does take 1 to 2 people, depending on the security level of that inmate, and it takes them out of the facility doing their detention officer positions in order to get them actually in front of the doctor to start getting them on these programs. The current challenges that we're kind of going through, we can't do telehealth with Peerview. They aren't able to get us insurance to be able to cover them as far as their malpractice with inmates. The way the insurance companies are set up, they make some ridiculous decisions about inmates aren't considered patients if they're telehealth, which I don't understand that. But so we did talk about it does require officers to be doing transports for every medical appointment, including opioid use disorder appointments for getting on the mat. Another challenge we run into is inmates are responsible for their medical costs per Montana Code annotated. And once an inmate comes into the facility, Medicare and Medicaid gets shut off as soon as they walk into the facility, and it doesn't get turned back on until they leave. So how that works per Montana Code annotated is the inmate gets billed for those services for the first 120 days. And then after that, the county picks up the bill and we try to find a way to recoup our costs from the inmates.
How do you do that?
So what we do is with our partnership with Peerview, we have it set up where they're on a sliding scale fee already. So we pay peer review directly to make sure we have a good partnership with peer review, and they don't have to wait the 4 months to get their bill paid. And then we go back and put a fee on their books. So if they get money coming in for commissary or phone calls, we end up taking half of what gets put in to make up for the fees that they don't have money on. But like we have individuals that are on Hep C medications. We have one guy that's like, was it $7 or $8 grand a month for his medications? He doesn't have any money on his books, so the county ends up just eating that cost because we can't stop somebody from doing that. So with them going to an outside provider, we have to go off of what they're able to do and be able to get them their money to be able to cover what we can and cover with the rest of the county budget. For substance abuse issues in the jail, I'm sure nobody's extremely surprised, but about 1/3 of our population in the jail, as of Monday, when I pulled everything and I ran through it, had some sort of substance use offense, whether it be DUI, possession, distribution. 1/3 of our 164 inmates, I believe it was on Wednesday, had these charges. And that's not counting the ones that are just there on probation violations because of drug use. So those numbers could go up even more with individuals that could be suffering from opioid use disorders or other substance use disorders.
So, sorry, quick question. You said they have an SUD offense, so that doesn't necessarily mean
They're
probably
not,
do, but
they're not diagnosed.
right.
I don't have an ability to get them all diagnosed or do anything like that. But if you're in our facility on a 4th offense DUI, I would imagine there's a very high likelihood you have a substance use disorder, because you tend not to get your 4th one if you've learned your lesson after the first couple. We do also have a large number of inmates that self-report during our booking process that they use drugs, they use substances, and that they have these issues and ongoing things.
How is that? Do they just initiate that, or is that part of a question they're asked?
Part of our booking questions and our medical questions is we go through and we just flat out ask them. So it's a self-reporting thing, but they are normally pretty honest with the officer because they're not looking at getting charged anyways, just by telling us, yeah, no, I'm gonna detox from meth or fentanyl or anything like that. So they're a little bit more honest with our detention officers than they are with our street guys. Yep. So the medical provider program that we presented in our proposal, what it would be is we'd be able to contract with the provider to get them into the facility to reduce our transport costs, get more access to medical provider to the inmates. Because right now, if we have somebody that screens in for the MAP program, it could be up to 8 to 12 weeks till we can get them to an appointment. Because even though that's an issue that we medically want to get them for, we have to triage what we have. And if I got a guy with an abscess tooth that needs antibiotics now, he gets the first transport before somebody else, because as much as your opioid use disorder might be a long-term issue, I got to worry about making sure that guy is not going to die of an infection. So a lot of times we have to triage what we're doing based off of that with our transports and what we have available. The other area would help us out a tremendous amount is having standing orders for our nursing staff. So right now our nurses aren't able to do some of their basic stuff that a normal facility would be able to, with a doctor providing orders for, hey, you show up and you see this abscess tooth, this guy needs antibiotics. With a provider, we could do a quick phone call of, hey, this is what I got, this is what I'm seeing. They can provide the order, and then we can actually get those medications going a whole lot faster. Right now, if somebody shows up with like an abscess tooth, we have to schedule them with an appointment, transport them over there, then transport them back, and then wait for their prescription to get filled and delivered to the actual facility. So we're talking adding days to our process of getting somebody medical care. We would also be able to start establishing standing orders for withdrawals, standing orders for alcohol detox, those type of high liability things where people are going through those withdrawals and those detox. We can actually have standing orders on base so that way our nurses can identify it without having to drag them to the ER or the urgent care in order to get an order from the doc to be able to do anything. It would also help us support our MAP Bridges program. So most of you should be aware, if you're not, we do have a MAP program that we partner with Criminal Justice Services. We do have partnerships with Peer Review, with Ideal Options, and with Helena Indian Alliance in order to be our providers. But again, a lot of them require transport or prior contact with the person coming into the program. A lot of people coming through our jail, that's where they start getting those services for when they transition out of the jail, is when they come into the jail. As much as we try and do any other outreach anywhere else in the community, the focal point seems to be when people come to jail, that's when we start realizing, or they start realizing they need help, and we can start getting them connected to services. So having a provider would help us with having somebody there on a regular basis to identify, diagnose, and get people started on Matt Bridges' program. So that way, when they transition out of the jail, they're already set up on the program and are set up for success when they get released. I would also, I would love it because it would also reduce our transport costs to the county. If I'm not having to transport people to medical appointments all the time, that frees up that officer to do all of our other transports that we have to do across the state of bringing inmates back and forth, and also be able to bring people back into the detention center to actually do detention officer duties rather than running around to appointments. So there's 3 different areas of the mediation guidelines that kind of get hit by this proposal. The first one is one of the core strategies for MAT distribution and other opioid related treatment, because it would increase distribution of MAT to individuals who are uninsured or whose insurance does not cover the needed service. A large number, I would say probably 80 to 90% of the inmates that come into our facility are Medicare or Medicaid. And as soon as they walk in the door, that gets shut off. So 80 to 90% of my jail population is uninsured.
And that's also VA benefits.
Those get shut off?
And those are federal laws that I would love to continue to combat and try to get fixed.
How do you ever recoup your costs?
We don't. It's just an area where we just kind of bleed money. So this would help us with not having to have as much medical costs, because if these funds are provided for this program, these people, the inmates, aren't going to have an additional charge for their services, both opioid use disorder, but also the holistic approach of everybody in the facility for their medical needs, if they can be handled for urgent and non-emergent. It helps the inmates save money, and it helps the county save money with our budget of not having to try to recoup those costs later. The second one would be under the core strategy, section F, providing evidence-based treatment and recovery support, including MAT for persons with OUD and co-occurring SUD mental health disorders within and transitioning out of the criminal justice system, and increasing funding for jails to provide treatment to inmates with OUD. I think they kind of wrote this section of the recommended guidelines, really understanding that your detention center, your local detention center, is the nexus for people to start getting into services and get treatment. A lot of people aren't going to seek out treatment until their life starts going to shambles. And unfortunately, when they walk through our doors, that's when they start going through shambles. So the more resources we have at the detention center to divert them for when they leave, so they don't come back and become a revolving door, the more ability we have to be able to address some of this stuff. We have stuff in place to address these things, but it takes so much time to get it done with having to rely on outside providers, rely on outside mental health providers. By us being able to contract with somebody with these funds would help us to be able to speed this along, get people set up for success right away, rather than having to kick them can down the road for a couple of weeks or a couple of months and then try and get them set up.
When you say provider, are you talking about a physician or a nurse practitioner or some?
Physician, a physician's assistant, or a nurse practitioners. We've looked at multiple ones of those, and either one of those would meet our need in the facility for our urgent but not emergent needs. They'd be able to provide basic prescriptions, exams, procedures, and then any one of those 3 would also be able to oversee our Matt Bridges program to make sure we're addressing the opioid use disorder stuff as well.
Right. And you said you have nursing staff currently?
Yes.
Are those county employees?
Yes.
Okay.
Yeah, I have 3 nurses right now hired. Starting September, we're going to be adjusting our schedule again. We're going to be able to get less of our traveling nurses, rely on more of our actual county employee nurses, and be able to provide 7 days of coverage, 12 hours a day with our nursing staff. We have looked at other options of bringing an outside contractor. The issues are it would cost us about twice as much to do so. And with us having county employees as nurses, we actually have a team feel between our medical team and our detention team. We're all one team trying to work together to solve a problem. They get a better understanding of our security concerns. We get a better understanding of their medical concerns. So we get a chance to be able to actually build those decisions based on what's best for the inmate in the facility rather than fighting each other and butting heads that you see in a lot of other facilities.
And last question, is there a medical director at the jail or some medical person already overseeing kind of care?
Right now, there's not. So everything gets directed towards peer review if there's any question that's not covered underneath the scope of a registered nurse.
Right.
So if there's anything that they aren't able to do under their license, they have to call peer review or the emergency room to talk to a doctor to get direction from that person. And then it's multiple people, multiple fingers in the pie. We're not getting consistent answers. You get a different one from each doc.
Thank you.
Yep. The last one it falls under is under the treatment, providing evidence-informed treatment, including MAT, recovery support, harm reduction, and other appropriate services to individuals with OUD and any co-occurring SUD mental health conditions who are incarcerated in jail or prison. And that one's kind of self-explanatory. Not only are we helping address the OUDs, we're helping address the mental health concerns with mental health medications, other substance use disorders as far as alcohol abuse or anything else that could be coming through. And it also helps us provide that non-emergent care for the entire jail population. And the healthier the population is, the whole lot easier it's going to be for detention, a whole lot easier it is going to be for them when they get released and put back into the public. If everything lingers and festers, people are going to mess up a whole lot more once they get out.
So if somebody comes in and then they are diagnosed with a OUD and then they get onto MAT, and when they get out, then what happens to them?
So that's where we would also be working with our criminal justice services like we are now. We have agreements with peer review and HIA for those hot handoffs when they're available. When they're not, we do provide medications with a follow-up, trying to get them into their provider, either HIA or peer review, as soon as they practically can to continue their treatment on the outside. So that's where the bridges comes in with our MAT program is. So it's not just we provide MAT when you're in jail and then once you get out, sucks to be you. We connect them with local providers to be able to continue that treatment as they continue on rather than just having to fend for themselves. Some additional benefits, we went over some of these. They provide non-emergent care for the entire facility, not just individuals with opioid use disorders. So I have 164 inmates, 160 to 170 on a regular basis. Like we talked about, a third have those disorders. We might even have up to 50% have a substance use issue. However, by just providing services to only 50% of my jail population, we're not really addressing the entire community needs. So this would also provide medical care for the entire jail population, not just the opioid use disorder stuff. It would help me immensely with reducing my transport, both for medical and opioid use issues. Right now, with us being as short-staffed as we are, I have one guy that does transports. And he has to coordinate transports from other facilities to us. If an individual gets picked up for a warrant from Lewis and Clark County and Billings, we're responsible for going and getting that guy and bringing him back. So he tries to manage those with the medical appointments, along with our mental health transports to and from Warm Springs for different hearings, along with transporting people to and from prison back and forth. I got one guy that's doing all of that. So if we can reduce a little bit of that workload on that one guy, it allows him to focus on all the other stuff and be able to provide a lot more services to the county. And then it would also increase our effectiveness of our nursing staff by having those standing orders, that direct medical director, that consistent answer from the same person rather than multiple people. Nurses are able to actually know what to expect, know what their doc's going to want them to do, and work as a team a lot better to understand how to approach stuff.
And just for a little insight, so just today we were booking medical appointments and we were booking inmates with appointments at the end of August because we were having to coordinate transports as well as the peer review provider's schedule. So we have inmates who've been here since June who won't be seen until the end of August. So this would allow us to expedite their care, whether it's physical health, mental health, substance abuse disorders, or, sometimes all three. So.
So the financials that he asked that we put in for our proposal, we worked with a local provider. He was actually a physician's assistant who reached out to us. He's former special forces, so he was interested in helping out in the detention facility and kind of getting involved in the community. So we discussed with him how this possibly would look like having a provider. He gave us a rough estimate. And so his rough estimate would be about $115,000. $115,200 a year. So the ask is for the next 5 years to be able to kind of push that out, to be able to get a chance to have some stability with our medical provider rather than just going off of 1 year. So it comes out to a total of $576,000 over a 5-year period. With that, that's based off of the estimate of having 160 inmates in the facility, because his estimate was based off of how many people were in the facility on an average on a day. With us being able to save money with transports, with our medical costs that we're already having to eat by being able to do even less than that. Even if it went above that $115,000 that's funded here, the detention center would be able to pick up that overage with our budget every year in order to be able to cover the rest of this if it does go above what we're asking for.
Over the course of everything, we thinking this is like essentially a full-time employee, 40 hours a week, or?
Nope. So basically the doc we talked to, the way he envisioned it with his price, it'd be about 15 to 20 hours a week of him coming in and providing a clinic, but then also being available by phone for our nursing staff if they come across something. And then just stopping in, checking in every now and then, providing feedback, building that team with the nursing. But it wouldn't be a full-time type of a position. This would be a part-time gig. And that's about what we were paying before for 20 hours of a physician anyways, when we had an employee position within the county.
I have a couple of questions online, if that's okay.
Sure. Go ahead, Wes.
Thank you. The first one is the grants that we are able to recommend are for 3-year periods, but you're seeking 5. What's plan B for years 4 and 5?
I did not know. I didn't see that in any of the instructions that it was for a 3-year period. So that's why I put in for a 5, just to kind of give us one. But even a 3-year period, that works for me. That provides at least some stability rather than just doing 1 year at a time and having to jump through the hoop and not know if we have this going. So if I missed it in the instructions, but when I saw, I don't think it was in there, but that's why I picked a number of 5 years to give us stability going forward.
Okay. And then the second question is, you've referred to 160 inmates, which is your daily average, but you had also indicated that 1/3 of those inmates are the ones that may have possible OUD or other issues, but the cost is based on that 160 inmates. Can you square that for us?
Yeah. So the rough estimate that I had was based off of what their actually charges are. Is 1/3 have either DUI, possession, distribution, paraphernalia. They have some sort of substance use charge that's also in there. And if we provide just for the people that have OUD, that's wonderful and great. But it also neglects a huge need within our community with providing medical care to the entire detention center. And with this proposal and the provider, we're looking at providing a holistic care for the inmate, not just you have an OUD, we'll treat you OUD, but everything else we don't care about. So if somebody comes in with an OUD, but then they have a abscess tooth, or they have these other medical issues, and we just ignore everything except for the OUD, we're not really making anybody healthier. So by providing a holistic approach to the OUD community, we also want to provide that holistic approach to our entire population.
And I also think it's important to remember that jail is fluid. So the 160 inmates I have today are different than the 160 next week. So we could treat 10 people for OUDs this week, and maybe only 5 of them would be crossed over, and we would have 5 new ones. So in a 2-week period, it could be, you would be treating 5, and then 5 on each end, so 20 people. So, because people are coming in and out of jail, going to new facilities, being arrested, being released, being rearrested. So it's not the same 160 consistently. It's a really fluid population.
It could be more.
Yeah.
Is there any estimation of like the total unduplicated number of people this could serve over? I mean, we're talking thousands of people over the course of a year.
It's a very real possibility. The last time I pulled the numbers, we had 2,600 inmates come into the facility last year. Some of those are obviously repeat offenders and frequent flyers, but not all of them are. So, I mean, if you have 160 on a regular day and you have 2,600 coming in, it's kind of that ebb and flow. So this isn't just talking about only 160 people. This is the entire community when they run into this funnel point that we run into with opioid use disorders is the detention center and the criminal justice system. This is going to get us a chance to be able to hit those people as they're hitting that funnel point.
Question for you, Captain. My understanding is that you did have a provider in the jail some time ago.
Yes.
What happened? Where did you get your funding, and what happened?
So when we had that one provider that was in the jail, that came out of our detention budget in order for us to be able to do that. At the time, we only had 2 nurses then. So I only have 2 nurses to provide nursing coverage for the entire week because we need a nurse there every single day. So when we looked at that a couple of years ago, we decided we much rather use our county money for providing more nursing staff and partner with Peerview to try and find a way where it's still affordable for the inmate, but we're providing those urgent needs in order to have nursing staff there. And that's where we have 4 positions now available for nursing staff, is getting rid of that physician position, turned it into more nursing staff to have that immediate reaction, and a medical provider or medical professional there every single day of the week. So to me, it made a whole lot more sense to have 80 hours a week more of nurses than it did to have 20 hours a week of a physician.
Great. Go ahead.
I'm sorry. So you mentioned that Peerview can't do telehealth for insurance. Can anybody else do it?
Everybody else we've talked to has run into the same type of issues. The only ones that we have found that have been able to manage it is Helena Indian Alliance, and that's only for opioid use disorder. And they tend to be hit or miss with whether they're going to take a patient or not. So with them being selective of who they're going to take, we run into issues of we can get some in, but not all, and we can't cover our bases for everything that we need.
Mr. Chair.
Yes.
What happened to the VA if you have those vets in there? Because the VA does offer telehealth.
The
So
VA
are they
will not.
eligible?
The VA will not work with you once you're detained in a jail. They won't even transfer prescriptions or give us a medication list. So it's just and that's across the country. So, but it's a huge challenge.
And just like Medicare and Medicaid getting shut off, those are federal standards that they set. And unfortunately, I would love to be able to solve it in this group of being able to address that and fix that. But that's a federal conversation of getting everybody across the nation to look at it and go, okay, how we did it in the 60s might not be the best way to be doing it.
I hear you. We have some of the same thoughts, by the way.
And may I, the 115,000, that's the salary and benefits for one person at that.
So it's not salary and benefits. That would be the other nice thing is with our medical provider in the past, we had a salary, we had benefits, we had vacation, sick time, all that stuff that we had to manage as, well, it was my job as the detention captain. And you run into issues of, you got a street cop that takes over the jail and some doc has to report to them, but heads as far as who's actually in charge. The way this proposal is set up is we're actually going to contract out with an individual. So I don't have to manage payroll. I don't have to manage personnel. I don't have to manage benefits. He has his own private practice. The individual we talked to and built this model off of, he goes, this is what my fee is per inmate per month. Whatever services are needed, these are the services we provide. We don't have to worry about the liability either as far as malpractice insurance because it falls underneath his license, his insurance to be able to cover all of that. So with that being a county employee, we also run into, as soon as an inmate gets ready to sue, we have to go through with all the defense. We have to pay for the malpractice insurance. We have all those additional costs as well. And if you guys don't think we get sued, I think I have 22 federal lawsuits against me in the last 2.5 years just from running the jail. So we get them all the time. They're normally frivolous, but again, you have to go through and fight every single one.
How do we deal with the fact that not all of the people are that we'd be dealing with would have an OUD, and we're kind of learning what restrictions, what we can spend money on. But it would seem that we might be able to not provide the entire amount, but a portion of it, based on a third to a half of the people falling under a opioid situation.
So the third that I gave you is just the ones that have those new charges that are based on those substance use disorder. I have a large number of people with theft and burglary and homicide, all these other charges that aren't specifically stated as drug. But when you talk to them, homicide was created because of meth use and meth deals, and you have fentanyl deals and all those other stuff. They're stealing stuff for burglaries and thefts because they want to feed their drug habit. So just because they don't specifically have a charge that is tied to opioid use disorder or substance use disorder,
That makes sense.
there's normally a drug nexus behind most of our criminals within our facility. When somebody comes into my facility, unless it's like a first offense DUI and just some kid made a bad decision for the day, we're not arresting people for jaywalking. We're not arresting people for simple assaults. We're not arresting any of that kind of stuff. So the people that are coming into my jail have had larger crimes, and a lot of times the nexus of those crimes is substance use disorders. So if we limit it just to, well, we can identify these ones specifically, we think we'll have it and reduce what it is, what we're going to actually provide care for. You're going to miss a whole lot of people that aren't identified because of their charges. The other issue you're going to run into is if we have two different standards for how we provide medical care within our facility, I guarantee you I'm going to get sued and I'm going to lose a lot of money for the county because I treat people differently based off of what their diagnosis is. Where you show up and you have an opioid use disorder and an abscess tooth, boom, I got you care right away. You show up without an opioid use disorder charge and an abscess tooth, and I'm like, well, sucks to be you. You're gonna have to wait a week to get an appointment, and you end up dying from an infection. I now have to pay millions of dollars because you died. So really, if we just limit it only to this specific thing, we're gonna end up creating a situation where we're gonna get sued and we're gonna lose a lot of money. By providing it basic care for everybody, not only are we providing care for opioid use disorder, catching anybody that comes in our facility, regardless of their charges, that could have an opioid use disorder or a substance use disorder that wouldn't have been flagged beforehand. We're also providing holistic care for anybody that has an opioid use disorder or a substance use disorder. So you come in, you might have it. We don't have a chance to flag it, but I still provide you medical care on a quick and often basis. You become healthier. As you become healthier, you might want to start addressing your substance use issues as you leave our facility, regardless of whether you got diagnosed before or after you left the facility.
I would also tie that into medical issues, like, we get abscesses on arms from IV drug use. Dental problems, we're dealing with dental abscesses all the time. That's from drug use. It's like direct correlation. And then you have your mental health is tied to your substance abuse. A lot of these people have had untreated mental health for a long time, which leads them into substance abuse. So it's all intertwined. And then we see things like people who lose their toes to frostbite because they were really high in the middle of the winter and didn't have proper clothing on. So it's, it's all intertwined together. So
The other area that could also help, I mean, I don't have a way to quantify this for you, but if we have individuals coming into our facility with mental health issues and we're able to provide that care for them right off the bat, there's a possibility of stopping them from turning to substance use in order to address their mental health issues. So by just limiting it to just this narrow, it's only for this, it's expanding the treatment for the entire facility to be available for them if they come in with these opioid use disorders and substance use disorders.
We're talking about approximately $3,000 a week here. How many hours of support does that buy?
About 15 to 20 hours, like we talked about. So
and the standing orders are huge. So we're really limited without a provider right now. So there's lots of things we can do as nurses, but we have to have an order. So we can lance things, but if we don't have an order to lance an abscess, we can't do it. So we have to ship someone out. Or if we have someone with a UTI, we know that's what's going on. We've done a Euroscan, everything, but because we don't have a doctor, we still have to send them out. So with having a provider, not only do we have 20 hours of them helping us, we also have these orders that we can act on as nurses without a doctor present. So,
and if you break it down by hour that we're getting for dollar amount per hour, when we had a physician in the past, we were paying about $100 an hour just in the base salary. So once you add benefits in there as well, we're talking almost about $135, $140 an hour. So if we get 20 hours for a contractor coming in every week, plus all the other stuff, we're already looking at $150 an hour for that contractor. So we're paying an extra $10 to $15 an hour of, we have less liability on the county, we have better service, we have more care, and we have more access than we would if we hired one out ourselves. So that's where I view, after looking at all of our scenarios, of contracting out with this is going to be cheaper and easier for the county than it is going to be if we had to go and hire our own provider again.
And the 20 hours a week is enough to meet demand for this holistic care.
Oh, yes. So right now, we normally can get 2, if we're really lucky, 3 or 4 inmates to peer review a day out of the 160. By doing an in-house where we don't have to do the transports, we don't have to do all the extra stuff, we can start knocking out, we can pick days for our clinic to run them 2 to 3 times a week. And if I've got a 4-hour block and the individual is able to just bring people down, we can do a lot more than 2 to 4 a day.
Any other questions from the committee? Do you want to kind of summarize and
Yeah, no, I mean, as we kind of went through all this, the proposal we're asking, we're trying to find where that nexus is, where most people are actually going to be receptive to treatment and get where they need to be. And as much as you might want to do community outreach, which is wonderful and great, and I think we should be doing that as well because it's a multi-pronged thing, the biggest funnel for people that are going to want help and actually accept help is once they start having their life kind of come down a little bit. And that's unfortunately where we work in the jail. So I think this program is going to be a great tool to not only help people with opioid use disorder, it's going to be able to reach more people than just going around and doing any type of other outreach. Because the people that are at that point that they need and want help, they're coming through our doors on a daily basis. So, and I appreciate you guys' time and questions and kind of going through everything. And throughout the process, I'll be available. And I'm here for another 12 and a half years until I look at retiring. So I'll be around if you need any follow-up questions or anything else comes up. I can certainly answer those for you as well.
One follow-up.
Mhm.
So I guess my concern is you get them in the jail, you get them connected with care and everything, and then they leave. As we're looking at other proposals on how we try and kind of shore up this framework of trying to eliminate OUDs and overdoses and deaths, is there you said there's a warm handoff, and is there something else within that that would be helpful? Because yeah, sometimes a handoff is not enough.
Unfortunately, there's really not much else that I can think of. Rather, I mean, short of me driving everybody to their next appointment. And unfortunately, not unfortunately, me personally, I think there needs to be some responsibility on the
sure,
individual
for
as well.
Yeah.
I mean, you can take a horse to water, but you can't make them drink. And if we can set them up with, as soon as they walk out the door, they have their medications with them for the next 5 days. They'll hold them through with the Matt Bridges program. They have an appointment set up. They know where to be, when to be there. I feel like we've done everything we can for that adult to be an adult. And we've set them up for success as best as we can. Really, anything further than that, they didn't really want the help anyways. And it's gonna come back around, and they're gonna come back through my doors, and we try again with, we're gonna try and set you up for success. But it's up to you once you walk out the doors for you to follow through with the plan that you have. And as they keep coming back, the consequences get more and more in the criminal justice system, but we can still continue to treat them with trying to get them on the right path when they eventually get out.
So other than just the medication, is there an addictions counselor that's tied in with all of this?
So we already have a licensed addiction counselor employed by the county within the detention center. We've got one mental health therapist in the final background phase to be starting full-time. We have mobile crisis response team that comes and helps us out with that. We have a programs reentry individual that works Monday through Friday to try and get people lined up for services. And we already have a mental health case manager that helps us out with the Matt Bridges program and connecting people with resources on the outside for planning when they go through. So we already have those in place. This is just going to help us supplement with getting those processes done faster rather than having to wait.
Could you take a moment and just kind of explain the handoff and the work with the department that's called criminal justice service?
Yeah. So how the warm handoffs work is it's a worker that's with Peerview or Helena Indian Alliance. And if somebody that's on our Matt Bridges program is going to be getting released, if we know ahead of time, we try to coordinate to have that hot handoff already scheduled, ready to go, so that they have an individual that's there with them to make sure they're on the right path. Unfortunately, we're a county jail. Sometimes we have no idea if somebody's going to get released until it's, hey, their bond showed up, it's time for them to get released. So we can reach out to those providers, but if they don't have any available, that's where we provide, this is when your follow-up is, this is who you need to talk to, here's your medications for continuing on your medications. That's how those hot handoffs really work.
Any other questions from the committee? Staff, do you have any other questions?
I do have one additional question, Commissioner.
Yes.
Maybe this is for our questions, though, for the future. But if this is not 100% tied to, as the current application was written, tied to opioid abatement, do they have the opportunity to revise any of the contract? Because after hearing it further and learning about the possible avoidance of opioid use, that's helpful, but I didn't read that as much in the initial application. So a question for the Maine Montana Trust is, do they have the ability to revise that contract, or can we, the application, or can we include our heard comments as part of the application materials? So maybe Amanda and Ann, if that's something that we can discuss with them in the future.
Thank you, Wes. I think that's a good thought. Anything else?
Mr. Chair, I'd be happy to add that to our list of questions for the state.
Great. All right.
So to kind of answer that one, the very first one that we talked about, the core strategies, it wasn't just to treat people with OUD. One of their things was, increasing access to the Matt Bridges program within those populations. And that's where I feel like this program, even though we're providing care to the entire facility, we're meeting that for core requirement of we're providing greater access to the actual Matt Bridges program by having a provider. And so I think that's how we kind of go about with looking at, well, it's not just you only spend this money on opioid use disorder people, it's how do we provide the better access for them? And I think providing the better access is providing the better medical care for the entire facility, which includes a lot of people with opioid use disorders, substance use disorders, and those type of issues. So I can kind of understand where you're looking at it with, oh, this is about opioid use only, and we should be spending it on there. But even within their core strategies, they're talking about just increasing access to these programs. And that's what we are looking at when I wrote this up and built this proposal was this is going to increase access to a large number of people coming in that could have this. If we just limit it only to, oh, we only spend it on people like that, we're not really increasing our net to be able to catch more of these issues before they become bigger issues.
Okay. Anything else you'd like to add?
Nope, I think I've talked well over my 5 to 10 minutes. So
No, I think this has been very good to do that. Just a pause for here just a minute. To the other members of the committee, I try to leave it open and kind of free it back and forth. If we ever get into a situation where that doesn't work, I mean, we'll go to more formal question and answers. But I think as we can make it work this way, in a fairly open setting, I'd like to continue that way, unless you have a problem. Okay. All right. Thank you very much, Captain.
thank you.
Thank you very much. All right. Let's go on to the Helena Public Schools.
Well, thank you. Good afternoon. We appreciate it. Well, while you're still here, it was fascinating to listen to what you were doing. So, and it's kind of for us, again, thanks for having us and allowing us some time. It's interesting that you have two organizations that are looking at this grant money. It's incarceration, detention, public education, kind of a scenario that, or common themes that you'll hear. We're looking for additional resources, in-house support, more efficiency through it, and increase in expenditures for both the jail, as you hear, and through the school system of a landscape that's changing in education. It's different than it was before. So I brought with me Lana Carter, because Carter was Jefferson Elementary principal for many years. I won't say how long, but we brought her in. I asked her to come down to the district office and really run our mental health, be a mental health administrator for us throughout the district. And the reason why is that we see our mental health needs across the district, probably across our community, across our state and country, are escalating. They're increasing. Student behaviors, of course, are escalating as well. So we really recognize the fact that the mental health needs of our students and our families, our staff, need addressed. And there really isn't a mechanism across the state or even the federal side of how those are funded. And so we've been out looking for resources to enhance the ability to proactively work with our students and our staff. This also is one of those opportunities that we look forward to have the opportunity for more resources for our students, and that's why we're here. We serve 7,600 students. We have nearly 1,000 employees, so we see a large portion of our community within our schools. So the gist of the program and what we're asking for is really at the hands of Lana. She's sculpted and crafted this, and so we'll turn it over to her, and I'll be available for questions and support. So Lana, this is yours.
Well, some of you know me because when I first got this position, I spent a lot of time working with stakeholders in our community that had a lot more experience around these issues than I did. So you'll know that I've continued to do this work, and I'll be mentioning you both in just a moment. So it was interesting to me in that the sheriff was speaking about about 30% of the population having a OUD. About 30% of our population, when you look at our students self-reporting through the risk surveys that they take every year, are using substances. And what we're seeing is that the use by our youth is just dropping down into the lower grades. So right now, for instance, I'm working with Bethany Coe from prevention, and she's helping us with some vape curriculum because we know that kids are starting to use pretty consistently in 4th and 5th grade. And we haven't been really touching their lives with education around use until middle school or high school. By the time we do our formal education around some of these issues, kids are already hooked. So kids start vaping, they're hooked. And kids have vapes, and I'm sure you've seen every size. Their parents don't know they're using during class time, they're using in the bathrooms, it's just rampant. So they pretty much go from vaping to they jump into marijuana if they can, and that has greatly increased with legalization of marijuana and alcohol use. And then from there, they get into the harsher drugs. They also have them in their homes. Their family members are using, and they're leaving substances around their homes that, we hear about when I was a part of the task force, kind of talking about how this money would be used. Toddlers stumbling into it and ingesting it by accident and having to be revived. So from my perspective, as I try to craft a district framework of support for our students and our families and our staff members, substance abuse and prevention is really the next slice of our pie of what we need to work towards. We have a very dedicated school counseling staff that work very hard to serve kids during the school day and throughout their experiences as they get older. But they're school counselors. They're not licensed clinical therapists. They're not addictions counselors. And there's a difference. We have a fabulous school nursing team who work with families all the time around medical issues, but they are becoming more and more of a primary care service to our families, especially with the number of families that were dropped off of Medicaid. But again, they're not addiction counselors, although some of them, it feels like, have put in the hours, right? So have been able through the last couple of years to create some really fruitful, I think, for our community, not just for our school district partnerships. We have a very strong partnership with both Peerview and Helena Indian Alliance. And as of this autumn, they will be in all 5 of our 612 schools. As Dr. Petarski knows, we have an MOU with Carroll College where we really want to start bringing in our social work interns and providing them experiences in our schools, because we feel like we are the perfect space for those candidates to learn about what's happening in their community and what the mental health needs are of folks in our community. We have worked really hard so I'm adding to my job. So I'm going to be beyond mental health. I'll also have student services and special education. And so we're going to be really looking at how, because all of these services weave together to create a framework of support for our kids and our families, right? the piece that we don't have is that we had all the way, I've been in this district a long time. So all the way back in the Judy Griffith years, we had prevention specialists that were in our system. They were working with kids and families. They were making the connections that needed to happen so that our kids or our family members don't become incarcerated. And I really think, you have both ends of your spectrum in your two candidate pools, where I don't think that one is better than the other, but I think that we complement each other interestingly in that if we can prevent the number of kids and families that are becoming a part of the addiction cycle, then hopefully that will help in terms of the stretch of resources for our police and sheriff's departments. So the entire proposal is built on a prevention model. 2 social workers that would also each supervise an up and coming intern provides us hopefully a pipeline to get, whether or not those folks decide to stay with us, it creates an opportunity for us to get more mental health workers in our community. And if you talk to Peerview, Helena Indian Alliance, anyone, they are struggling to find qualified folks to retain and to maintain in their system. But we need to have that person who is going to provide that link to care for families and be that that person that I can call in the school system and say, listen, my dad just got a DUI, or I just got a DUI, or whatever the use is. And it may not just be opioid, but we have opioid as well. And I need help, and it's not going to be punitive. It's going to be supportive. And we're going to get them to the resources and the support they need. Additionally, these folks would work in the schools and work with kids in classrooms, with staff. We've had some trouble because of the workload that we have right now and kind of stretched resources, getting some of the resources that we've gotten from some of our partners into our classrooms. We have some great curriculums that have been purchased for us that are not being used to the extent that they could be because we simply don't have that teach it, show me how to teach it, and then I'll take it over model, where I feel like if we had folks are worried about, where this fits into the curriculum, we can have folks in the classroom teaching the curriculums kind of along the line of how we do QPR now in our health classes, SOS in our middle schools. YAM comes into our 9th grade classrooms. We really need a continuum of curriculums that continue to talk to kids about risk factors, choices, and most importantly, that there are resources and we're here to support you and help you and your family if you will just let us know that you need it or that your behavior shows us you need it, right? So it said 3 to 5 years. I read it as 3 years, but I always ask for more because that's our, kind of where we're at. But I'm hoping that as I kind of dive into this new position and we begin to look at possible funding sources, we are looking at whether or not we are accessing Medicaid to the extent that we can. We want to work with the Futures Generations Commission and see whether or not that school-based health is a way for us to shore up our system as well. I'm a member of the state school-based health coalition in our state, and we've made a lot of really great progress around how to get barrier-free access to physical, mental, and behavioral health in our schools. But really, I think that we all know that we live in a state that has not only very high suicidality, but has incredibly high use levels. And we don't have the resources to get to kids when they're young enough that we can actually hopefully make a difference in their trajectory so that they don't just kind of step into all of the different options for use. And we also don't have the case management that I feel like in the work that we've done with RBHI, Peer Review, and the Helena Indian Alliance has really provided us kind of a window into if we are able to provide case management, we can get families on the right track and keep them on the right track, but we need to have somebody who's really, that's their job, is to work with these families and keep working on making sure that they are getting the support for a healthy environment for their children, for themselves, and so on. So I'm hoping that that makes sense, but I'm open to any questions. Yes, sir.
So kind of thinking back to the sheriff's argument that hiring is inherently expensive, more expensive than contracting.
Correct.
So is there an option to, and I know school-based services exist.
There is an option to contract or to hire as our own employees. Yep, we have talked to both HIA and Peer Review. And really that helps us because then they can do all the things that the sheriff talked about. And then it's not our.
Yeah, we truly think going down the contracting side is more advantageous for us, as the sheriff had mentioned. It's just that partnership, and they take care of all the HR that then their people come work with our folks. So it makes more sense for us to contract than hire our own.
And the point of having the paid internships was because I couldn't get your kids to come work because they want to be paid, and you understand that, right? If you can have a paid internship over a free internship, you're going to take the paid internship when you're putting yourself through college. So we really wanted to enhance and entice them to come and be a part of the work that we're doing. Other questions?
I think, Colleen, you had a question with the sheriff for the detention center about that handoff. I think that's a really important piece that when they're 25, whatever age incarceration, you're an adult. We gave you the tools, go be an adult. We're a little bit different. We're like, we will work with you forever if we had to. And that handoff it's not working with a student and saying, tell mom and dad, this is what's going on. We see a real need for a link between the school district, the student, and their family. We want to work hand in hand with the family. So the handoffs they're well communicated. They're not isolated into a third party, that we can communicate what's happening with HEPA and understanding what we can and can't talk about. So it's really important for us to have a person that's connected with the family and the student, because sometimes, believe it or not, students don't tell their mom and dads exactly what we're saying at the school. I know that's crazy, and vice versa. And so we close those bridges. We open the communication up with our families as well. And as you know, a lot of our homes are broken. They're in lots of ways that means, but we have multiple homes where students live, or not at all. We had about 150 students that registered for homelessness 2 years ago, and we're up to over 400 this year. And so those workers, the people that we want to help our students, sometimes don't have parents to support them. And so we see this as a great link and bridge between what we can serve and what we should serve.
We also we've added the Handle with Care, about that piece. We also have the Montana Cares app now, and that's a pre-K, it will be pre-K, K-12 app where folks can go online. They have 988 services. They can give us tips. We've gotten many tips, especially from middle school and high schools students who are saying, hey, kids are doing things that they shouldn't be doing around substances, and can you respond? Or I'm really worried about my friend, they just took this and we want to make sure they're okay. So I feel like we are beginning to niche away at the worry about tattling or thinking on somebody, because people are worried about people staying alive. They're worried about what their friends, their family members are taking and getting into. So having that resource for our kids and families, for us to get that information, share it appropriately, and then get those resources to those kids and families, it literally will save lives.
Is there?
I do have two pieces, one question and a comment. Thanks, Superintendent, Ms. Scanlon. One of the things that, or Ms. Carter, excuse me, one of the pieces that I wanted to make sure to mention is similar question, Ann and Amanda, that we discuss that this role may take on other things beyond just opioid abatement. And if that's a possibility for funding purposes, because it sounds like there's a lot more need, obviously, that these social workers as well as the interns may be working on, and if that's allowable through the cost mechanism that the trust allows. The second is just for awareness, we do actually have 14 applications. We just have 2 that are strictly within Lewis and Clark County. The other 12 are statewide or partially statewide. So we're also weighing our recommendations based on all 14 applications, not just 2, just for your awareness of that.
Thanks, Wes. Yeah,
That's
good to know.
In terms of the piece about whether or not you can spend the money on anything else, my understanding was through the application, if you're looking at what I submitted on page 3, how does the program meet the opioid remediation guidelines? These were guideline points that I took specifically out of the application requirements, including hiring mental and behavioral health workers to provide or expand any prevention, early identification, and referral services, creating school-based contacts that parents can engage with. I won't go on, but I listed 9 of them that I think do meet the qualifications of some of the guidelines that were placed in the application to apply. So I'm hoping that I met that threshold.
I did the same thing. When looking at it, the name of the grant is Opioid Abatement Trust Grants. And so my first inkling was that it has to be centered around the use or abuse of opioids. As you look through the application, there is a preventative strand that wants to initiate action proactively before students engage in opioids. And so that's the mechanism, the formula in which we built this, or Lana put this together, constructed it around the prevention and the mental health prevention, so that kids are not in a position where they escalate later. We want to deal with them before they see the detention center. And that's the avenue that we want to explore. I hope that this on the state level, that they see it the same way that we do. But we really want to work proactively rather than reactively.
Questions from the committee?
I have a couple. It wasn't clear what the focus population was. K through 5 was mentioned, and then 6 through 12 was mentioned. And so I wasn't clear which one you're targeting.
All of the above. If I have 2, I would love for this team to be able to respond not only to specific grade levels, but to provide guidance for the district in terms of prevention of use. So when you're looking at little people, typically little people aren't using, but their family members are. And so last year I had many phone calls from elementary school principals saying, I need help. I have a, X grader whose mom is addicted and dad is in jail and they have no resources, and right? So we're not actually going into a second grade classroom talking about opioid addiction, but we do badly need that link to care so that we can link that family with resources. At the 4th and 5th grade level through about 10th grade level, really some solid support on training all staff. I'd like all staff to be trained, but that's the staff that needs to really be trained on what the different, what the different vapes look like, and working with kids and having these conversations and getting those curriculums in place so that we're really not only educating in that 150-minute health block, but we're doing something more systemically across the system. In terms of I feel like the high school counselors and our partners with Peerview and HIA are doing a really nice job of making those connections for those families that have that high need in the high schools, and now will be at both middle schools. But Rex is right, our homeless population is exploding. And those kids, regardless of age, and those families, regardless of age, have significant needs as well. And many of them are living in the motels around town and so forth. And there's some significant dependency needs. I think it's a lot of self-medicating. And if we could get them connected to care, potentially we could get them off of their substance, getting more appropriate care, and getting them on a more positive path.
According to a 6th grader from C.R. Anderson, we have solved the homeless problem. I received an email from him saying, "Dear Mayor Collins, thanks for everything you're doing. We have enough houses in Helena. Please do not talk about affordable housing anymore. Please bring Chick-fil-A."
Oh my God.
So,
Everyone's paying attention.
Yeah. Priorities are straight.
Yeah. Well, I'm kind of with him on the Chick-fil-A, but you mentioned the naloxone and the test strips, but there's nothing in the budget. So who's paying for those?
We actually get those through the public health department
Okay.
now. And our school nurses have them.
Both of them, both things, the strips and the naloxone?
They have access to the strips. They have the naloxone.
Okay.
The strips are interesting in that I see the social worker as being a good, it is difficult to give, pardon? Yeah, it's difficult to just hand strips because, right, school employee, but a social worker who's working with a family saying, we want your family to be safe and healthy, that's more appropriate.
Absolutely.
In our opinion.
The social work will be a nice, again, handoff conduit to provide services where it's a little more difficult for Londa to hand those out in principles.
Yep.
Good question.
And then you mentioned several evidence-based prevention programs. Are they ones that you already have? Are you looking at buying one?
Those are ones that we have right now, although now with me shifting into my new job, I'm going to be meeting with administrators to say, okay, is this, because this is what we've been doing for a while in our system, as you know, and I really want to look at that and make sure that we're still following best practice in terms of the programs and the levels that we're providing information. So that's on my to-do list. That's growing.
We've been doing them for over a decade, and it's time to ask, they worked then, do they now? Is there something better? We want to ask that question.
Yep.
What's working out there?
And how to get that youth voice in the room so that they're able to say whether or not it's making a positive impact for them.
We're here.
That's important.
Some of the kids are coming back, telling us, yeah, we've heard YAM a lot. We can try something different. Yeah. So they're talking to us.
Yeah. So one of my concerns was you mentioned developing an awareness campaign. And then who's paying for that and who's developing it? Because just putting stuff out that's not best practice can do more harm than good.
Amen. Yes. So part of my new job is creating, either accessing through partnerships, appropriate information. I feel like I have a lot of really strong community partners who are wanting us to be able to share more information with our families. I feel like through the Montana Cares app, we've been able to share much more information if they go into that resource portal and they're able to look through there. So I don't think it's so much building something new or having to pay for something new. It is making sure we have the right information available to our kids and our families. So that's the way I see that.
Okay.
I also see, with student services being kind of a new look, our webpage for that department will be getting a upgrade as well, so that we would have a place where people could go in and find resources if they weren't using the app.
Okay. One last question. Sure. What was it? I just lost it. Oh yeah, 2:00 in the morning.
You
can
have
email
my
us.
number.
I do. Referrals. Are you still using the Connect referral
Yes.
system? Okay.
Yes. Yes, we are. Okay. We're also, a lot of times it is also through going from our teacher to our school counselor to one of our partners that way, but they've been pretty darn good, I think, about using Connect. Yes.
Okay. That's all I got.
Any others?
Heavy prevention focus,
Heavy.
training,
Yes.
and just for my information, I mean, for those kids who are actively using, who have an opioid use disorder, I mean, do you have a sense of how many of those there are in the district and what's being done for them, if any?
Rex asked me this question too. What we have is, it's difficult because what is being shared with their school-based folks and what's happening with their school counselors is, we try to preserve those relationships.
Sure.
There is some, I can tell you our Prime for Life classes are filled every month, and that is a referral for any kind of misuse of chemicals or substances. So we know, and then I have anecdotal, that's not hard statistics, that kids are telling us about 30% of them are actively using the number of opioid. I don't have that number.
It's self-reported, and then we know that 70% of our students have experienced.
And that's
Those
also
ones.
self-reporting.
So
They've experienced
they're dabbling. They're experimenting with
some kind of
something.
Okay.
Yeah, what alarms us is the gateway drugs, is the vaping early, 5th grade, 4th grade, that they're experiencing now, to getting used to it by 6th grade. And, obviously we know what comes from there is that they keep pushing the ante, experimenting with higher doses. And we're seeing that go in. The amount of that is increasing and the age of it is decreasing. It's just getting younger.
That's not good.
No.
We do have great staff. Our counselors do amazing work, but they can't. High school, they're career counselors. They're advising what pathways to go and making sure credits are correct, and yet their mental health most of the time, and that's the same in the middle school. And so the supports. There's a story that I have that when I asked Lon to come down, what made this happen is that there was a student mental health needs, abuse, suicidal, and depression. Met with family off campus. The family determined with the high school counselor that a student needed additional support, and they went to seek that support at one of our facilities in town. The counselors debriefed real quick, went back to their office, and that young man was sitting in the office waiting for the counselor to come back because there was not a resource in town for that young man, which tells me I'm not playing this game. We need resources and we need support for students, and our counselors don't have it, but we need mental health. That's why our connections in Purview Indian Alliance and having counseling clinics within our buildings are important, but we also know that we need that into the middle school and elementary, and with additional support, so social workers that help families and students even at a younger age.
I've written 3 large grants for, I haven't gotten any of them.
Yeah, we're right.
I'll keep trying though.
Yeah.
3 large grants to put mental health teams in our schools. I really believe that if I can get the start and we can get ahead of how ill kids get, how critical they get, we can show that having the prevention will not only pay for itself, but it will save lives. And so getting the opportunity to prove that or is the challenge, right? Because we simply, as hard as we try, we don't have the money in our budget to do this right now. So.
And that's not on you. That's a state and that's a federal concern that I'll take up with legislation when it's time. But right now we are doing everything we can to fund support for students. That's why we're here.
Other questions?
Mr. Chair, if
Yes.
I may, and I just want to note this is a state's application process. So other than you guys reviewing it, there was no input on building this application from any of the regions. So the annual budget, 197, but you indicated that you're looking for 3 to 5 years of funding.
Correct. That is per year.
I just want to make sure that this committee and
that's a good
the
point.
state's records show that, because they do for the detention. Okay.
Okay. Anything else?
Thanks
Any
for
other
catching that.
Pardon me?
Yeah.
No, I'm telling you, it was a good catch. Thanks.
It could have been perceived as 197 for 3 years.
That's how.
Yeah, I wanna make the annual budget. Yeah.
You want to be clear about it. Yeah. Anything else? Any other questions? Well, we sure appreciate you coming in, appreciate you doing this. We're kind of feeling our way through. It's going to probably take us a little while to, we're just kind of getting started. So.
Yep. We appreciate the opportunity to come and present to you. So thank you.
Thank you.
Okay.
Reach out to us if you have any questions.
Or if you have any insurance.
I'll let Molly know. Let Molly know you're asking.
I never stop.
Never stop.
I tell you.
She's here.
All right.
Thank you.
Okay, I thought you might be my neighbor.
Oh,
Because
thanks so much.
Thanks again.
my email.
Yes. Okay, thank you
My
so
neighbor
much.
across the street actually has an election sign with her congressman.
Oh, seriously?
And her dog's name is Winnie, and I live on Winnie.
Oh, that's
So
funny.
it's like vote for Winnie,
Oh.
pro dog park, pro ball. Yeah.
So I thought what I'd like to do now is just talk a little bit more about priorities.
Mhm.
And I really appreciate the suggestion from Amanda to let these folks come in.
Yeah.
We probably let that go a little bit longer, but we're kind of feeling our way into this.
Yeah.
This a little bit. Is there? Have you had any thoughts about priorities? How we can kind of set where we need to go and where we need to have our money focus. We'd like to talk a little bit about that. And one of the things that's has been for me personally is it seems like we're struggling on the treatment side, and I feel like that treatment is where there's a big block, and it looks like the legislature maybe is getting the word that there has to be some extra funding there, but I don't know.
I can tell you that, yes, they are. Heck, I've gone to the 872 commission meetings and they're very treatment focused as far as the continuum of care. They're all on this side. even though I keep saying you're not going to fix this side until you invest some money on this prevention side. So, as of now, they haven't put any money towards prevention. There's not a dime from the heart funding that's gone towards primary prevention, even though it says it's supposed to in MCA code. So there's my prevention spiel. So yeah, I agree. And I was thinking that too. It would be nice to know what they're going to fund so that we're not duplicating efforts.
Right.
Yeah.
One of the questions I have asked, do we have to make a decision on these things now? Or are we better off to wait until maybe the next quarter before we assign some funding?
I don't know. I think
Until we kind of get a better feel for what's going on. Any thoughts in that regard?
I think we should.
Wes, go ahead.
Sorry, Mayor Collins, you can go ahead.
No, I just think we should move forward because these entities are looking for this assistance, and if we can do that, but we should at least first get some answers from the state on those questions, unanswered questions that we have.
Yeah.
And that's just where I'm at.
You've provided some. You're going to write us work on a letter for us.
Mm-hmm. Mr. Chair, you should all have a draft of that letter with you today. I apologize that I didn't get a chance to get it out in the packet last week. I did my best to summarize. I think there are a lot of questions still lingering. Again, a lot of them are ones that Anna and I have asked, but hopefully the 3 seals and our chair people's names attached to them may carry a little more weight, and hoping that we can get some clarity on this. Again, this is just a draft. I'm happy to add to this before we send it, and we don't need to decide today. You can take it and
Let's
read
just
it
take a minute and maybe have each of us read it, and let's see if there's any immediate things that come up.
And the comment I was going, if to that letter we could add that question that I had just about, can we take into consideration what is being said, or is it strictly off of the application when we make our recommendations?
All right.
And then in addition to that, Amanda, my last name is Feist.
My apologies.
That's okay. Happens all the time. But I worry a little bit about saying, yes, we want these 2 to move forward when a large portion of the funding is coming from the 12 other applications that are in. And so I don't know that we can commit ourselves to recommending applications when we don't know how we're to proceed with the statewide or regional types of applications.
So Wes, on some of the information that we got last time, there is a grant distribution schedule, and there is an amount for each abatement region plus each metro. So it looks like 2 pots of money, one for just Lewis and Clark, and then one that we can have a say in the abatement region. Is that right? Or do we need to use some of ours too?
No, ours is part of that, because if the region, even though Lewis and Clark County resides in a region, we are our own region also. And so we only have, I don't even think control is the right word, but recommendation of just the Lewis and Clark County region, not of the greater region. But from my understanding and the way the applications are laid out on the portal is if it's including Lewis and Clark County, that's us to make the decision. So that's all 14 of the applications would take from our pot of money.
But on this distribution, there's a separate amount for each abatement region too.
But those are for the other counties in the region, not part of the metro.
Okay, gotcha.
Is how I understood it from our conversation with them in our initial conversation.
Yeah, I think you're right.
Okay.
Well, I haven't read through all of them, but I've read through some, and there's a couple that are going to be a hard no for me. So, for the abatement one,
I put a lot of them on hold because in my opinion, those questions, those unanswered questions
Mhm.
need to be answered
mhm.
before you can really say yay or nay, because I just have too many questions for quite a few of them.
Well, and I think one of the questions we had was if it's a multi-year application, can we choose to go year by year, or do they get the entire amount up front? Is that on? I don't see this question on here.
I think we asked something similar to that too, and it was that we would have and now I don't remember if this was just a question we had, do we have the ability to say, whoa, this application, we approved it for 3, but it is not going well. We need to pull back, or to just get a reoccurring, yep, we all think that it's a good idea to move forward in the future for each future year.
It would sure seem that we ought to be able to review it,
Right.
and say, these folks are doing a great job,
Right.
or they're headed in a different direction than we thought.
Right.
Yeah, so if we only fund it, even though it's a 3-year application, if we say we're only going to fund 1 year at a time, then they would only get that 1 year and not get the entire lump sum to.
Mr.
Yes.
Chair, committee, Amanda and I did have this conversation with the Montana Opioid Trust people on a separate conversation. And what they indicated, I think is what they initially told us, was they will only fund projects for 1 year. Those annual reviews will come back to this committee, even if the initial, ask was for 3 years. The state is only going to fund projects on an annual basis.
Okay, so that makes it easy.
Yeah.
That answers that.
Helps. Yeah,
It
Okay.
does.
good.
For budgeting reasons, though, you should be prepared, I think, if you approve a 3-year project, that
Right.
those
that it
monies
might
are going to
come out.
likely be tied up for 3 years.
Mhm.
So
Right.
And do we look at an inflation escalator and that sort of thing?
I think that's up to them. If they didn't put that in their application, that's on them we would be approving what they requested, not anything additional.
Okay. All right.
Is my opinion.
Does anybody have any suggestions for the letter?
We just add the new ones there.
Okay.
Yep.
Let's go ahead. Let's go ahead with it. Okay.
Sounds good.
All right. All right.
So we have.
Let's go back now. Let's talk a little bit about our priorities. What has everybody got thoughts on? Are there certain things or certain parts of the funding that we want to prioritize?
To Colleen's point, I think my only thought on that is it depends on what applications come in, but what we recommend for funding would be a balance of prevention and treatment. But I struggle with saying this is what we want to do, where maybe none of the applications come in like that in the future. But as we recommend funding, we try and balance, is it going toward all pieces of opioid from prevention to treatment?
Mm-hmm.
I agree with you.
I agree too.
Is that it? Anybody, any other thoughts? So that each of the 3 areas that they list would be equal priority.
Yeah, that's a good way to word that.
Okay. All right.
Well, there's prevention, there's treatment, recovery.
Yes.
So.
Yeah.
So I'm sorry, I missed recovery in there.
Prevention, treatment, and recovery.
You have
So each would have they would have equal priority. All right.
Unless there's a bunch of funding coming through the 872 commission
Mhm.
and the heart funding.
So long as it also hit our region, yes.
Right.
Yeah. Yeah. All right. Now, let me tell you what I did in mine, and I think let's talk a little bit about the applications that are out there. I took a hard look at these two, set up kind of and responded to them. And my thought was I'd go back in and after having heard from these folks, kind of modify it a little bit. But haven't looked at the ones that seem to be multi-district applications because I don't think we have the direction yet that we need that maybe this letter will get for us. I think that we should prioritize if they don't do it for us. I think we should prioritize things that are happening in Lewis and Clark County. Isn't that? Would that be an unfair thing to say?
No, until we get directions, I think that's the fairest thing to say.
Yeah. Okay. All right.
Oh, yeah. I mean, some of the applications are statewide that would address, in Helena.
But they're kind of diluted by being statewide.
Mhm.
Right.
But if they offer like telehealth to expand services, then that would be, a good thing.
Okay. All right.
Have we looked, I haven't looked at any of these multi-region ones either to see how their budgets are built. Like, are they going in and looking at the allocation each metro area or region has and pulling that into a larger sum of money? Because that,
I kind of got that impression that's
Okay.
what their attempt is,
interesting.
or at least on some of them.
And James, I looked at that and put percentages on all of them. So I didn't do the last one that we just got, but the 13. And so there are things like the detention center is 19% of our annual allocation, where there was a stabilization expansion of childhood early intervention services for southwestern Montana. It's 8.3% of our local annual allocation, but it's 2.2% of the multi-region annual allocation. So for the regions that they selected, it's 2.2% of the total allocation, but it's almost 10% of our annual allocation.
Okay, thanks, Wes. That's great.
Yeah.
Would you mind sending those calculations out?
No, my notes are in there too, but I'm happy to send that. I'll send it to Amanda and ask that she then disperse that.
I think that would be helpful.
Yeah.
All right. Any more thoughts on where we should go from here?
One priority for me as I look at the two we met with today is at their evaluation plans. And a lot of them are proposing metrics that to me are more just outputs versus outcomes. I want to see like reductions in use or increases in scholastic performance or something. I mean, what I hear is a lot of families served or numbers of visits or stuff that I think doesn't really to me speak to impact. And so I mean
But I think that's what the focus had to have been. Because if we're looking at like the CSCT program, talking about their focus is how many they will serve, how many they can get out the door. But our focus here is a little different.
Right.
And so we will have to give them that guidance to say, hey, this is where we're looking. And so it's hard for them to focus on what we want when they have not been there. So,
that makes sense. And I don't know how we go back and give that direction, but just that's a priority for me individually as I'm reading these applications is how clearly articulated is their evaluation plan and how are they really articulating outcomes that really are about someone changing for the better versus trips or served or something.
I mean, the school would have the data through the PNA or the YRBS as far as youth use, and then they could have dropout numbers and, I mean, that kind of stuff. So, but I don't know how the jail would even remotely come up with outcomes.
Yeah, the jail was, I wish there was a way they could build in a better screening or diagnostic process in their grant, because it still feels like there are people who have opiate use disorders who are not going to get, they might get treated for an abscessed tooth, but are they ever really going to be diagnosed as needing treatment? But then again, is that treatment even available to them?
Yeah.
So,
Yeah.
They're in a tough spot.
yeah.
Mhm.
Well, that's the way both of them felt like they're struggling with systemic inadequacies,
Right.
and they're trying to use this to like plug holes. You know, it
It's
just
the Swiss cheese.
yeah.
Would it be fair to go back to each of these two we heard from and ask for them to share with us what kind of results, measurable results they would expect at the end of the first year? Or maybe there's a better
How
way
would
to.
the jail follow through with something like that?
Yeah, I don't, that would be tough.
That's
The jail
tough part.
it would be very difficult for the jail because when they get out, they're done. They're going wherever.
Yeah.
It seems like in the case of the jail that they're relieving some of their officers from doing other things
Mhm.
by having this assistance.
Yeah, that's the point.
So I don't know how you would do that. I almost wonder why it hasn't been a priority within the current budget at the jail. If this is
Yeah.
a real problem.
When you go back to here, what I hear from the judges is 80% of crime is tied to drugs. So it goes back to stopping it before it starts.
Yeah, but even 30% of middle schoolers, that is freaking huge.
I'm not hearing that we want to go ahead and make a decision today.
Oh no.
No,
Okay. Well, let's say that we're not going to make a decision today. Now, how do we proceed from here?
Yeah, what's our next step? We say, no, we're not gonna decide today, but then what are we gonna do?
Yeah,
let's send a letter. Let's get some answers. And we convene.
we'll send the letter to the state organization, ask for their response. When it comes back in, get it back to each of us. What would be the anticipation? I would think we'd get some kind of a response within a couple of weeks, or am I smoking something?
No?
Mr. Chair, Committee, the last time we spoke to them, there was still 4 regions that didn't have this committee set up.
Wow.
And so there's 4 regions, and I'm not sure which ones they are, that they don't have a contact with to even discuss their applications that came in just to the region, much less to these multi-region. And so I'm not sure if the state will be in a position to answer those until.
Let's give it a shot. Let's let them know.
I think the pressure on them is going to be helpful too, to say you want our answers, but you got to get everybody else on the same page.
Has anybody else approved anything as of yet?
I doubt it.
I doubt it on the multi-region, but we can ask that question.
Yeah, let's add that. You know,
Are we just so far ahead?
We
We just slow down.
Slow down, right? We need to slow down.
all right.
If I might, Mr. Chair.
Do it. Go ahead.
Just a clarification question. Within the letter, that last paragraph, and this was the general consensus that I got at the last meeting, so I want to make sure that we're still on the same page. I indicate to the state that we would not be providing recommendations until we receive feedback on this. Now, that was a wholesale full stop, we will not be providing recommendations until these are responded to. Now, I just want to make sure that I'm clear that the committee isn't interested in wanting to move forward with providing a recommendation on local Lewis and Clark only
Right.
applications. Either we're just not going to provide recommendations. I just want to make sure I'm understanding that correctly. But you don't want to move forward with local and just table the state applications, or if you want to table everything until you receive.
I think we could move forward with maybe more requests from on these local ones, don't you think? We could be.
I think those are coming in whether they're organized or not, it seems, with this list of, the statewide stuff.
Mhm.
And to your point, excuse me, Mr. Chair, Committee Member Smith, of the my understanding is that the MOT, the State Advisory Trust Committee, will be meeting in the second week in July. Whether they have recommendations from anyone at that point, including our committee, I'm not sure. But that's when they're scheduled. I did let the state's staff members know that our committee had decided at the last meeting to slow things down a little bit, and we might not have a recommendation for them. So they are prepared for that as a potential outcome.
Okay. All right. Maybe we should put in there that we're going to meet again at a date certain, and we'd like to have answers by, say, the end of July. Do you want to do that, or?
I think the end of July is too far.
Okay.
Yeah, that gives them a whole month. Certainly they
that's
can
too much.
answer us before that.
Like middle of the month?
Yeah. 3 weeks,
think-
that's middle of the month, yeah.
What are your thoughts?
The middle of July?
Middle of July? They're going to meet on what date again?
I wish I remembered off the top of my head. I think it's the 7th, Chairman Rolfe.
Let's give them a week after that.
The 17th, is that what you said, Amanda?
I believe it's the 7th, council member.
That's a Sunday.
I was thinking it was the 17th.
And maybe it's the
later than
17th.
that.
If it's the 17th, let them give us some answers before then.
Yeah.
It might be the 7th. I apologize that I don't have that right off the top of my head.
That's okay.
I saw.
What's the second Monday of July? What is it?
The 10th.
That's
Second
true.
Monday in
Second
July
Monday?
is-
Oh, no, I'm sorry. The 8th is the second Monday.
14th. Oh, this is the 15th.
Third Monday.
That's the 3rd.
The 15th?
Oh, yeah.
Second
Well,
would be the 7th.
it'll be the 8th. Let's shoot for the 8th. Okay, let him work. We're working. Let him work.
I don't. Let's do this. If you'll find out when they're going to meet, and then let's tentatively set our meeting for a week after that.
Okay.
All right, and tell them that we'd like to. We would tentatively meet a week later than that, and we'd like to have something to go on at that time.
Yeah.
Does that sound reasonable?
Yes,
Sounds
sir.
great.
Okay.
Yep.
All right. Is there anything else that you'd like to cover today?
And do they even have a way of looking to see what kind of applications might be in the pipeline? I mean, we have 2, but who knows, we may get 12, local next week. And so that's kind of one of my hesitations is I want to see what's coming. Is there a deadline also on applications?
no.
It's just
It's
rolling.
rolling. Yeah.
Interesting.
Rolling with, I think, the understanding that they'll be reviewed quarterly.
Okay.
Okay. So you'll find when they're gonna meet. We'll ask for a response to go with that, and that we would intend to meet a week later, and would like to have a response to our material for that meeting.
Happy to do.
All right.
Yeah.
All right. Anything else that we need that the group wants to bring up?
Don't forget to call public comments.
Is there any public comment? Is there any public comment?
Mr. Chair, it is only us in the room and.
Hey, we're
So
getting
there's
there in the
no-
law.
There we go. Well, let's move forward. Let's move on. I think that if everybody's satisfied with where we're at, we will plan on a meeting a week after approximately a week. And I would like for our meetings to start at 1:30 rather than 1, if that is okay with you.
Fine with me.
Is that?
And then how far would it go? Because 4 o'clock we meet here.
Pardon me?
4 o'clock, the city meets in this room.
Oh, is
So
that?
if we're meeting 1:30, that will push us to like 3:30.
Uh-huh.
And I'm just saying at 4 o'clock, we use this room for our administrative meeting.
Okay, so 1:30
On
would work.
Wednesdays.
Would work.
Yeah.
Yeah, okay.
Yeah, Commissioner, to that point, I do understand that the clerk's office needs to be in this room at 3:30, so it would be a hard out at 3:30.
All right.
If we were to keep them at 1:30.
And if we get any more applications in or any more information we need to share, you and I can work together, try to have as soon as we get a response from the state organization, we'll try to get a meeting agenda set. Okay.
So you'll send an email trying to find a day that works for everybody then, once you find out from them.
Yes,
Okay.
and generally speaking, our Wednesday's good day, Wednesdays at 1:30. I mean, I know things pop up, but we'll keep that in the back of your mind as you're scheduling other things. That would be helpful.
All right. Thank you. Really appreciate your support,
Oh my
and
gosh.
appreciate Ann's been
Mhm.
fielding some things for us as well.
Yeah, absolutely.
They're good people. So
Yeah.
Definitely.
if nothing else, we're adjourned.
All right.
Thank you all.
Colleen, I found stuff that came in from
Thank
the
you.
National
Thank you.
County Organization in our little newsletter that